And get started. Thank you all very much for joining today. We have what, in my view, is a really awesome topic and timely, although I think it is not necessarily the most fun to think about topic area. And it's taxes and funding and how we fund public health and the work that we do and the services that we deliver to in our communities. So my name is McCullough. I'm a professor here at Boise State School of Public and Population Health. And my background is in sort of health economics and public health economics in particular. So this is a topic area that I really enjoy talking about and looking into. And hopefully you'll leave today with a little bit better understanding of how our public health system is funded, some of the challenges that we face in understanding how our system is funded, and some of the implications of the ways in which our services are funded and therefore delivered. So I will go ahead and start sharing my screen here. All right, you should now be seeing this slide. And so today, as I mentioned, how taxes impact the availability and delivery of public health services. So we all know money does not grow on trees, though understanding where public health funding does come from, it takes a little bit more work than just going out and plucking it from the tree. And it sometimes can help us as practitioners understand priorities and possibilities and the inverse of that sometimes. And I wanted to take a minute just to state that today's presentation is what academics call positive, not normative. So something that is normative is sort of what something should be, whether it's good or bad, we agree or disagree, the norms of something. The opposite of that is positive. It's just what it is. That doesn't necessarily mean we agree or disagree or understand or anything like that. It literally is just, this is the way that things are. So today's presentation and the way that I will be presenting these materials is more in a positive way. Again, this is what things are. It does not mean that I endorse the way that things are. It does not mean that this is the way that things should be. And I wanted to state that just to sort of level set a little bit, and also to make sure that it's hard not to get too much into politics when you're talking about taxes, because taxes are almost inherently political. But I'm going to try my very best to keep things steering towards just sort of a report on how we fund and deliver healthcare system, public health services, rather than getting into the politics of what we should or shouldn't do and ways we should or shouldn't do things, that type of stuff. So positive rather than normative. So thinking about your role, what organization you're in, oftentimes when we're working in a health agency or in any agency that for that matter, our budget comes from our boss, right? At the beginning of the year, our boss tells us, hey, you have this amount of money to work with, or you have this amount of money to deliver the services that you need to deliver, or whatever. It's just sort of a number that comes to us from on high. And where does their budget come from? Well, probably from their boss. And then you can keep asking that same question. Where does their budget come from? Where does their budget come from? Pretty quickly, if you turn into a toddler and you just keep asking why, things get a little existential, right? I don't know, and I don't know what the concept of money is, and where are we even on this big Earth floating through space and all these things. But there is sort of a sweet spot in there, right, where you as a public health practitioner can hopefully be asking a question of sort of where does this funding originate from, without getting so lost in space that we lose sight of the ground. So we're going to be a little bit big picture, right? I'm not going to be talking specifically about one program in one community or in one health agency, and where your specific budget comes from, because a lot of times that's a really specific question that you may already know the answer to. It doesn't have a lot of generalizability beyond sort of the specifics of one area. However, there is a lot of principles and practices that do apply elsewhere. So we want to hopefully hit that sweet spot today. So setting the stage, public health funding. even though there is often some solid ROI or return on investment to public health, meaning when you spend money on public health, you get a pretty good return on that investment in terms of money. There's little privately funded public health work. So we don't do public health work because it has a great ROI, but I wanted to set this stage to basically rule out a whole sector of type of funding that we need to look at, which is private funding for public health. Essentially, almost all funding for what's called core public health functions comes from government. Various levels of government, but it is government nonetheless. There are also nonprofits and foundations that contribute a lot to community health. So even though it might seem like we need some basic Econ 101, we also just need to understand taxes. We need to understand government spending and government budgets. Again, I'm going to try to keep this at the sweet spot, right, between too granular and not generalizable and too broad where we all just like zone out and lose interest in talking about this admittedly somewhat niche topic. So I did want to take a quick second to compare and contrast spending and contributions to the public health system from governments versus nonprofits. It is, believe it or not, harder than you'd think to get a clean estimate of how much is spent by the government on public health. I'll go into that in more detail later, but for right now, a good enough estimate is probably about $180 billion a year. That has changed a lot during COVID, and it's a little bit higher than it was pre-COVID, but roughly $180 billion a year. Nonprofit hospitals, on the other hand, is almost certainly the second largest contributor in terms of nonprofit health-oriented groups. This is just in terms of public health, by the way. This is not getting into more social services, more welfare type stuff. This is really just health and public health specifically. So comparing some per capita funding levels to get this on a little bit more of a understandable measure level here. State health department, the median state spends about $80 or $82 per capita. So $80 per person per year by a state health department. Local health department spending, let's just call it $50, $48 per capita. So $48 per person per year for every person that lives in that community, in that local health department's area. Nonprofit hospitals, which is again, your St. Luke's and St. Al's of the world, they are required to spend, and they do oftentimes just want to, even if they're not required, to spend money on community benefit activities. That helps to justify their nonprofit status, and also is usually a big part of the mission of these nonprofit organizations. On average, the total per capita spending for that is $130 per person for nonprofit hospitals. Only about $11 of that goes to what we might consider to be public health, meaning community health improvement and community health building. Community building activities. The remainder of that largely goes to clinical care. So discounted clinical care services for people that have trouble affording it, discounted rates for serving Medicaid or other populations. So it's not that that money is not important, but in terms of the public health system, what we are really narrowing in on is that $11 piece of that pie. So you can see state health department and local health department spending is kind of I don't want to say dwarfs, but it's a very, very, very important piece of the puzzle, even if we don't say anything negative about $11 per capita. Just looking only at $80 and $50 per capita, it's important to understand where the funding for that 82 and 48 comes from, and that comes from essentially from tax revenues. So let's talk taxes. So what happens when I pay my taxes, or when anyone pays their taxes? There are many ways in which we pay taxes to the government. And again, this is this is positive, not normative. This is just the way that things are. Other places can do things differently. This is the way that we do our taxes. So federal and state taxes, for most people who are employed in sort of a let's just call it a W-2 position, sort of a full-time position with a large organization or agency. Every other week or every month or so, you get a paycheck and taxes are withheld from that paycheck. So that's money that you never even see in your bank account. At the end of the year or on April 15th, happy tax day, that is reconciled by you and sent with a final sort of ledger for what you earned, what you already paid, and the total amount that you owe for the previous year. So today we are paying our taxes for the calendar year 2024. We also pay local taxes, and we pay those both to county or county equivalents as of a lot of things, but often property taxes is the big one. If you own a home, you're familiar paying these property taxes. In Ada County, at least, we pay them twice a year. I've always found it a little bit confusing because you can pay at different times and whatever, but the fact of the matter is, over the course of a year, you owe a certain amount based on roughly the value of your house. If you rent, you don't pay those property taxes directly. Your landlord hopefully does. And then you would help pay for those property taxes most likely through your rent payments. So you wouldn't see it, but it would still be something that you are most likely helping to contribute to. We also pay local taxes to our cities through a variety of ways, notably sales taxes is a big one. And governments use these taxes as revenues to fund what they do. So the federal government uses some of the money that you give them and that corporations give them, and from all the sources that they acquire money, and they pass some of the money down to state or local governments. State governments use some of the revenues that they get, and then they pass some to local government. State government also what's called passes through some federal funds to local government. So that it sounds like a little niche, like a little under the hood, or like unimportant. And to an extent it is. Like it may not affect our jobs or our daily lives or whatever, but there is actually a lot of importance in that a lot of federal funds come from federal agencies, and the ultimate destination is a local agency, but in the middle there is a state. So it's in part because of our federalist system that the federal government doesn't usually send money straight to localities, with a few exceptions for the big ones. Usually the federal government sends money to the state, who then sends it along to the local. So there is a state agency in there that passes through some of those funds. And then the local governments generally use. It's not all that common for local governments to send money to states or federals. It happens, but for the most part, the funds flow from big to small. So if there's any, so this is a figure that was in a recent Congressional Research Service, CRS report on federal funding and state and local funding. If you're interested in the rough estimates of how this actually looks in practice, these are the numbers. You can see there's a fair amount of revenue that flows from federal to state. About a third of 36.1% of state government revenue comes from federal sources. And then a lot of, 28.2% of local government revenue comes from state sources. So funds are flowing from federal to state to local. And an analogy that may or may not be helpful to those of you who like to hike, if you spend any time on the Ridge to Rivers trail system, you may be familiar with signs like these that bikers yield to, I hope this is the right version of this sign. Anyways, bikers yield to hikers, and everybody yields to horses. So like there are some sources and places that are always sending money down. Sometimes you're getting money in at the state level and sending money out. So it's sort of this complicated, multi-layered thing. But at the end of the day, everybody has to yield to someone else, or everybody is flowing down to other entities or whatever. So just one more slide of unfathomably large numbers. Best I can tell, the federal government spent about $6.8 trillion last fiscal year. Um, without getting too far into the weeds, a lot of that is what's called mandatory, meaning the federal government doesn't really have any ability, at least on a day-to-day, month-to-month basis, to do anything about that. They are simply collecting money and paying for things that are statutorily required. Social Security is a big one. CMS, so Medicare, Medicaid, a bunch of other things. The rest is discretionary, in quotes, with about half of discretionary spending for defense. So you may or may not consider defense to be discretionary, meaning like optional, but the government does determine that to be discretionary. So I put this up here for one reason, or for one main reason, I should say. It's important for us to look at what we sort of can and can't actually expect to have in terms of revenues available for public health, right? That $3.8 trillion in mandatory spending, it's not like the government could like reallocate that to public health. It's not like we could just skip paying our debt interest of 0.6 trillion, which would be $600 billion. It's not like we could just like skip that and pay for more public health, or skip that to reduce the spending, increase spending somewhere else. It really starts to limit what you can actually look at in terms of available revenues that could support public health. So it's just maybe helpful to have that in mind. States, on the other hand, states spend about $3 trillion, $3.1 trillion. Most of their funds came from general sources, so like the state tax revenues that you pay in, or federal funds. States' largest spending is for Medicaid, education, and transportation. Local governments spent, as best I can tell, about 2.5 trillion. I have a hard time dealing with numbers this big. It truly is unfathomable to most brains how big $1 trillion is. So rather than focusing too much on that, just focus sort of on the general comparison that locals are a little bit smaller than states, and the federal government is considerably bigger than either. This may be a helpful way of thinking about sort of where budgets go. And I put this up here for a couple of reasons. One is to make sure that it's clear, one, that there are different portfolios of spending that take place for states versus locals, and sort of look at what the relative big versus smaller ticket items are for states versus locals. And also to think through then for your programs where your funding might be coming from, and to an extent why, but like oftentimes the why isn't quite as interesting for this topic area as it is for some others. It's just kind of, that's just the way that we do things, either period, or that's kind of the way we do things, and there's a law or a statute that supports why we do it that way. But a couple of giant bars to draw attention to would be that lighter yellow bar for states. That's public welfare, which is largely Medicaid. If you have lived in Idaho for any amount of time, you have heard the Idaho legislature talk about Medicaid spending and wanting to get that under control. And like mathematically, the reason why is shown on this screen right here. It's one of their biggest, if not their biggest, single item to deal with every year. And if you are trying to budget and you need to be looking at your big ticket items, so Medicaid is constantly under the microscope. Locals, on the other hand, they spend money on the same things, but you can see that giant blue bar here for elementary and secondary education. So some of that funding does come from the state, but a lot of that funding will come from local revenue sources like property taxes and things like that. So that's why you hear a lot more discussion of Medicaid from our state legislature, and a lot less discussion about funding for K-12, although there's exceptions there too. And you can see other sort of big ticket items or bigger ticket items for locals, like, we've got police, we've got health and hospitals that show up, and a couple other social services that we'll talk about here in a second. So what does this all mean at the local level? Well, you may already, if you're still with us here, congratulations. You've made it through probably the least connected part of the talk. But funding streams are complicated, and they are multifaceted, meaning revenues that you will get from for a program will most likely come from some amalgamation of federal, state, and or local sources. There are exceptions to this, and if you are in one of those program areas, I want you to know that is sort of a feature of one of those programs, that maybe a defining characteristic. And again, I don't know that it's good or bad per se, but it will differentiate your program from some of the other programs in a health agency or in a health portfolio. You may also then want to appreciate that if you like change roles or move up in the organization, that you would be expected to deal more with that amalgamation funding, the multifaceted funding. Specific funding formulas for public health do exist. It's not literally just like we throw darts at a dartboard and whatever number we land on, we get that for public health. I'm not sure that it's a great use of our time to go specifically into all of the funding formulas that exist exactly as they stand today. If nothing else, we are in a very active policy environment. So just because something is a funding formula today does not mean that it'll be a funding formula tomorrow or next year. In Idaho, I thought it was worth just talking through this. This changed a few years back. And it's always possible that it changes again. I don't have any inside information on it, but like it's worth keeping in mind that things are always adapting and changing. So just because this is the formula today doesn't mean it will always be this way. But in Idaho, counties fund health districts, which are 7 health districts in the state. Counties contribute to the budget of those health districts based on a formula that is comprised based on population and the housing market values for a county. So if a county has a lot of people and relatively lower housing values, they would be able to fund that proportionally, in contrast with a county that has much higher housing values and a lower population. So an example of this you can think through would be a county like, say, Valley County might have housing markets, especially in the last several years, that have kind of exploded in the McCullough area. There's not an enormous population, but this funding based on both population and housing market values would allow Valley County to contribute based on their resources and size, as it would differentiate Boise County or Ada or Elmore, things like that. Blaine County would also be another one that we want, that the policymakers that put this formula into place wanted to make sure that counties were contributing based on resources and general size. This is, in my humble opinion, one of the better funding formula that exists for local public health. In one, because we have a district approach, which is a pretty solid approach for setting up a public health system. But also there's a lot of parts of the country that don't do it this way. It'll only be on population or only based on something else. So the fact that we at least have both of these, I'm not going to say that it's perfect and could never be improved upon and should whatever, but it's at least a really good start in terms of a funding formula to make sure that we are funding our public health agencies based on availability of resources in a community. Cool, awesome, we did all that. And if you're still with me, fantastic. How much do we actually spend on public health? I teased that a little bit earlier by saying it's a little bit more complicated than you'd think. And then I said about $180 billion. Let me go a little bit further into the weeds on that. It's complicated because we have to make a lot of decisions and a lot of analytic assumptions when we are trying to answer that question. So what do we mean by public health? I would bet all of us on the call today have at least an informal understanding of what public health is. We all may have a formal definition of what it is, and I would be very surprised if we all have the same formal definition of what it is. So we need to reconcile that, because if we're thinking about different things, that will drive different answers in terms of how much we spend. Do we care about the health department itself? So blank district health, or do we care about all public health promotion in the area? Right, that's that piece I talked about with the state health department, the local health department, and nonprofit hospitals, right? Do we want to include nonprofit hospital spending? If we do, fantastic, but it gets incredibly complicated to do that. And the same consideration would apply for other pieces. So other foundations, other types of agencies, all that type of stuff. And do we care about all health department work if we're looking at a health department, or do we care just about sort of the core foundational pieces of public health? Again, this may seem obvious, and it may strike you as not a relevant question, but it becomes important if we want to compare spending across areas or across jurisdictions. Because if we do something here in Idaho that we consider public health, but is not what, say, West Virginia would consider as core foundational public health, it doesn't make sense to just directly compare the two spending amounts. And it doesn't make sense to just directly add them all up to figure out how much we spend. So once we have thought through all of those pieces, oh, by the way, this is the thing on the right here. You've just probably been staring at that as I've been rambling on about other stuff. Sorry about that. This is from some work I did with some colleagues a while back, where we tried to disentangle all this, where we tried to take seriously what these questions are getting at here, and came up with a better estimate for what we actually spend on public health. So that solid line at the top is what the official estimate of public health spending is. Roughly, what does that say? Roughly about $90 billion. You can tell that is pre-COVID, because I cited $180 billion earlier here. And we're talking about a little bit of different things, but you can tell public health spending has gone up considerably since 20, whatever that is, 18. That shaded area is what we think we actually spend on actual public health work. So work that the CDC essential public health services, the foundational public health services that we all may have learned about in a public health program, that is what that gray range is. So it's considerably less than the $90 billion we claim or thought we were spending. So I want to dig in here and talk about what it means to account for foundational public health services, kind of compared to the other, everything else, let's say. So here is a public health budget. As far as I can tell, the most common county name in the US is Washington County. So I Googled for Washington County public health budget. This is not Washington here, it's Washington elsewhere. And I suppose if you really wanted to, you could like take this and like re-identify which Washington County this is, but let's just focus on this as sort of an exemplar county from Anytown, USA. So here's a screenshot of their county budget. So as an arm of the county budget, this is how the Washington County Health Department is expected to organize their financial reporting. So using this format, let's dig a little bit deeper to see how this impacts our ability as public health practitioners to account for public health spending. So we can see here what they have listed is public safety emergency services as a line item, and then they get into this public health. They have listed all of the public health employees' salaries and wages. They have overtime, they have buyouts, they have COVID, they have retirement, they have benefits here in retirement, Social Security, workers' comp, all that type of stuff, computer equipment, telephone. This is just a budget for the whole department. So if you wanted to, you would have to go in and somehow tease out what Washington County spent on communicable disease control, spent on chronic disease and injury prevention, on environmental public health, maternal child family health, and access to clinical care. Those are not the way that Washington County organizes its budget. Those are not the category names that it uses. Those are not the categories that it uses, right? Some of these you can map across, but early intervention, for example, 4059, doesn't really map perfectly well to any of that stuff. Family maps partially to maternal child and family health, but I would argue you'd probably also want to put in there early intervention, maybe some health education. So it gets really, really, really hard to figure out what Washington County spends on maternal child and family health. And this is not because Washington County is doing anything wrong. In fact, they're doing everything exactly as they should be doing. Washington County uses a set framework for putting together its county budget. Part of it is based on where they get their revenues from. Part of it is based on best practices in sort of county accounting. But it is not at all based on the foundational public health services. That becomes hard if we are trying to put together estimates of how much is spent on public health. Because what do we mean by public health? Well, for a lot of us, we mean these foundational public health services. Other people might mean essential health services or various other things, but like if we want to count up how much we spend on public health, we do need to know what we are considering as public health. And we can't do that with the way that we budget in most of our counties. It's just a big disconnect. So it gets incredibly hard to get really good answers on what we spend for public health. So with all that said, I put the disclaimer first that we don't really know what we spend on public health. That doesn't stop us from trying to add all the stuff up. NACCHO, National Association of County and City Health Officials, reported in their most recent profile of public health departments that local health departments are at roughly $49 per capita. So for every person in a jurisdiction, they're spending $49 per person. It's slightly higher for rural areas than urban areas. You could probably make an educated guess that that has to do with some economies of scale, that it's just a little bit cheaper to provide services to a ton of people all living in the same area than it is to have to drive all around the place to provide services to fewer people. Excuse me. And it's ironically, though, more expensive for the largest jurisdictions than the smallest jurisdictions. So like that urban rural thing may be the reason, or it may be due to something else. So who knows what's actually going on there, but those were interesting findings. So I pointed them out and also pointed out what I think was the most obvious first thing to think through. I want to compare this with the Idaho County per capita non-hospital health spending according to a slightly different source of data. We are a little bit below the national, what health departments spend if we look at what we spend on non-hospital health, and we're at $38. So we're not talking about huge amounts of money here, and I will do a quick comparison here in a second. We're talking about like 30 to 50 bucks per person per year for public health. Now, again, this is a positive, not a normative presentation, but if you just, what the monies that we're thinking of right now is 30 to 50 bucks per person. So just sort of put that in your, in sort of when we're talking through scale. How does non-hospital health or public health spending compare to Medicare spending, so healthcare spending? You can see, one, it follows slightly different patterns. So I would guess that many of us have seen graphs that look roughly similar to this Medicare spending graph on the left side of the screen, where we're seeing very high spending or relatively high spending in sort of this Appalachia belt here. This is for Medicare, so we're looking at roughly, let's just call it $10,000 per person per year on that order, between $8,000 and $11,000. Compare that with non-hospital health spending, which is on the right-hand side of the screen. That we are talking about $15 per person. The highest category here is quite hard to see. I'm not sure what exact, I think there should be another green box right there that's missing for whatever reason. We're talking about like a couple $100 per person per year for public health here. And you can see it varies by state, it varies by county, and it was kind of surprising to me when I put this together because it doesn't follow the same pattern that you see in a lot of maps of the US. There's just sort of unusual findings. Each state looks a little bit different than the next. I thought that was kind of interesting. Let's compare public health or non-hospital health spending to social services spending. And you can see here, there's a little bit better overlap that if you think about public health as one of many social services, there's some overlap. There's some rough comparisons in terms of states that spend more on public health also tend to spend a little bit more on other social services. So we can see here that we're talking about a little bit more money. We're talking about several $1,000s per person per year for social services, which I'll go into in a second what all that includes. Versus public health, we're talking about a couple $100s per person per year. So what are social services? Social services are the things listed here. At the top is what on the previous slide was called non-hospital health. I'm kind of going all over the place with terminology on public health, non-hospital health, community healthcare, and public health. In part, that's because there's different data sources reflected, and it's in part because there's just some lack of agreement on terminology across the different data sources. It includes public hospitals. So we don't have a ton of those in Idaho, but if you think about like, Los Angeles County Hospital or King County Hospital or Cook County Hospital, those are quite expensive, and local governments do provide funding for those. Parks, natural resources, waste management, sewer, fire, protective inspections, education is the big one, corrections, libraries, transportation, and housing. As just a rough comparison, I put a couple things up on the screen here. Per capita healthcare spending in the US is now at almost $15,000. Just if you work for the state of Idaho, just your premiums for the healthcare insurance plan that we are offered comes to over $13,000 per year. That's both your and your employer's contribution to that. So we are spending a lot of money on healthcare relative to a lot of these social services. And again, I'm not going to get into whether we should or shouldn't, at least at this part of the presentation, in part because things are a little bit different, right? Providing a park is a little bit different than providing open heart surgery to somebody. But it is worth just like having some rough guidelines to compare what we are actually spending across these programs. Idaho Medicaid, as best I can tell, spends roughly $1,800 per person total. If you divide their total budget by the total population of Idaho, that's how much we're all sort of spending implicitly each year. Roughly 80% of that comes from the federal government. So that we could more easily see slotting in to this type of expenditure levels than our own individual healthcare. All right, so moving us on here to this final section of the presentation. So some things beyond just how much we spend on public health. It's worth taking a step back and thinking a little bit about how that funding happens and some of the gaps in that funding. So funding, as you can see on this, the left panel here, we originally enacted some pretty substantial investments into our public health system as part of the ACA. Those didn't actually end up coming to fruition. The green lines that or excuse me, the blue line that continues on here will eventually get cut down too, most likely. We see that funding for public health has remained flat since the Great Recession. So these are all inflation adjusted totals in terms of how much we spend on the foundational public health services. I mentioned it's really hard to get that information, so that it was quite tricky for us to do this, but we managed to do it. And we did a whole bunch of statistics to be able to prove significant blah, 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 p-values, all that fun stuff, that those lines are flat. So one of those statistical anomaly type things that was probably not needed and technically needed. But public health is also underfunded and understaffed. Relative to need, there are too few people working in public health. Relative to need, there's not enough resources going into public health agencies. To close that gap, we would need, pre-COVID, we would need 80,000 additional public health workers working in public health departments. That most likely is not in the cards without some substantial additional funding. But that's sort of where we are right now. And this is probably the main normative slide that I have in here, which is basically just a little bit of a logic check, a status check, that we know public health and other social services and a lot of other things that are outside of our healthcare sector influence our health. That graph on the left, the pie chart here on the left, is give or take our best understanding of what drives health outcomes at a population level. So healthcare is in there. It's very important to have good healthcare across a population. It's also very important to have good health behaviors across a population, or improving health behaviors. Relative to healthcare, that is arguably more important in terms of determining population health outcomes. Yet, you can see this pie chart on the right, we devote most of our healthcare spending, and this is a little bit out of date now, the 3.2 trillion has gone up, as it usually does. We devote most of our spending to access to clinical care for individual people. I'm not saying we shouldn't have access to clinical care for people. However, it is a little bit hard to think through the rough allocations of resources that we do day in, day out, year in, year out for public health at its, 50 to 80 to dollars per person per year versus the $10,000 to $15,000 per person per year for some other healthcare programs. So thinking through sort of where money for public health comes from and what it gets spent on, I do think it is important for us to at least be aware that this is the current allocation of where things stand. So I want to leave us with a couple of ideas in terms of how we can think through our budgets for improving health, not just for getting a couple more dollars into our public health program using the same streams that we currently have. You may be able to just talk with your boss and get a line item increase for next year, or prevent a cut for next year, more likely. But some strategies for budgeting for improving health. So we can start by looking at some shorter term, higher visibility projects. Leveraging partnerships can sometimes be a valuable thing. These are sometimes ways that you can build either a proof of concept that your program works, or evidence that it works, or enthusiasm that it might work. Some behind the scenes work can help set the stage for these types of things to flourish over the longer term. So it's not just getting a flashy high visibility project to put our name on. Like, we got to actually have the partnerships and the infrastructure in place to build on this stuff and sustain it over the long term. There is some continued and renewed interest in demonstrating the ROI of our work. That is a possibility in some contexts. And also ways that we can work to promote efficiency to make the best use of resources that we can. I've already done a couple of trainings or a couple of continuing education sessions on ROI, so I'm not going to touch a huge amount on it now. But I did want to talk through some like very innovative, sort of cutting edge strategies for funding public health besides just asking our boss for more money through the same channels that we've always gotten money from, and or asking for fewer cuts than we are currently anticipated to get through the same channels we've always gotten our funding from. One is a social impact bond and pay for successes. So these are a little bit more common in areas of the country that have a Federal Reserve Bank. It's a big partnership and initiative that the Federal Reserve banks that are located across the country are working on, like San Francisco and New York and Philadelphia and Minneapolis do all these things, where private investors pony up money up front in a bond that invests in prevention or health promotion. And then when the gains of that are realized, so when the person graduates from high school or college and gets a job and starts paying taxes, or when rates of disease go down or when rates of crime and incarceration go down, there's a financial savings or financial benefit to that. Those investors that put up the cash up front are paid back through a bond, through a social impact bond. You pay for the success of a program. So it's a very privately funded path towards increasing investments in the social services that do have a positive ROI. The healthcare sector could be a great partner for public health to the extent that there is a value-based payment movement flourishing across the country. Healthcare payers are being incentivized to fund health-related prevention and upstream interventions to the extent that healthcare providers are now being paid to keep people healthy versus cure the disease that the person walks through the door with. So that is still an emerging area, and there's some best practices that are coming out there, but I don't know that there's a huge, the scale wise, I don't know that the scale is quite there yet in terms of how much that value-based payment initiative would really like bolster the size of the public health system in our country. Some bureaucratic reform and agency de-siloing. This one could be popular given current political climates, but rather than having one agency that prevents the disease and one agency that pays to treat the disease, put them all together in one agency so that the agency that pays for a disease is the same one that is benefiting when that disease is prevented. Right now, there's this weird thing that happens where one person pays for the health promotion program and some other entity benefits from it. If we can get those silos taken away so that the budget is all pieced back together, it's a much stronger case for making that initial investment rather than just sort of hoping that we see the return on that on those gains. Block grants have come and gone in terms of their popularity and political appetite for block grants, but rather than funding narrow health promotion programs, kind of the same general gist that I was getting at with number 3, give the money for the whole goal of health and well-being, right? Rather than giving a little bit of money for this and a little bit of money for that and a little bit of money for the next thing, and then demanding specific work for each of those individual funding streams. Do it in a way that aligns the costs and the benefits within that block grant. Last but not least, this is pretty inside baseball-y thing here. It's sort of a budget technique for how to set a budget rather than just sort of opening up last year's budget and adjusting for inflation and calling it a day, or opening up last year's budget and cutting some areas and calling it a day. You really sit down and you say, what outcomes do I want as a result of all this spending? Right? Do I want more people going to school? Do I want more people employed? Do I want cleaner air? What do I care about? I, as a community in this case. And then allocate resources accordingly. And so that can be painful in that there are probably some organizations or entities or individuals who might be sort of left to the side a little bit, right? If we are focusing really intensely on, literacy, we may be investing more in libraries and maybe less in something else, parks, I don't know, something, you name it. And so the thing that this guarantees, though, is that it guarantees that we are investing in things that we care about. That can be really helpful, even if it is hard. So I'm going to leave us there. And do have a couple minutes here for questions. So I want to piece together, if you're interested in learning more about public health, we do have these public health program options. We have a BA in public health. We have a certificate in public health. We have an MPH and a PhD. I promise you, I am the only one in our faculty here who will make you talk through boring things like taxes and budgetings and outcomes and stuff like that. Others will have a lot more rich public health experience to add to the discussion. But if you're interested, there's our website and QR code. And so with that, let's open it up to see if we have any questions, input, comments, concerns. At the very least, wanting to make sure that we've all completed our taxes and we'll be in the good graces of the IRS and also funding our public health system. So feel free to either drop something in the chat. You can do it for the whole group, or if you want to stay anonymous, just direct to me or Haley and we'll read it out. Otherwise, come off mute and let's talk taxes.
Well, Mac, this is Sarah. I just want to say, wow, how did you, you're a master at making something that's really pretty hard to get your head around, manageable. So yeah, I appreciate you. We've been really working hard to kind of, I don't know, cash in or connect with the value-based payment models within hospitals, and thinking specifically about the work that we do with family caregivers, thinking that they would see a family caregiver as like a natural for where they may want to support that piece of the team, using value-based resources. We have yet to be successful in making that case, and wondering, your thoughts on what sort of case gets to how do we make our case for these things that they know are good, we know are good, but we need resources to continue them. What talks?
Boy, thank you so much, Sarah, and thanks for the question. It almost feels like a whole other training topic area, so I don't want to oversimplify anything, but it is hard in that, like, the way that I presented value-based care, it's as if the doctor just gets all these magical funds coming in and there's no barriers, whatever, and they know exactly who they're supposed to be responsible for and all these amazing things, and then they just have all these resources available to do all this wonderful stuff for them. And in reality, it's way less idyllic than that. But sometimes like, not to oversimplify it, but like the connections that we have here in Idaho, in our Idaho communities, can be incredibly impactful and important in that, like, it's not too much more complicated than, like, there's a handful of individual people at, name one of the saints, who are doing all this work. And when they are familiar with the Center for the Study of some topical area, for example, like, sometimes it's the people and they can, they've got a specific thing they want done, and they can, it just sort of, the stars align. Sometimes it is much more focused than that, in that it's like they have a very specific population or a very specific thing that they are working on, and they need help with that specific thing. And so even though in theory our goals are aligned, public health, we want to prevent disease and promote health, they're trying to do the same thing. It's not like they need, you know, maternal and child health educator services or something like that. So it honestly, I don't know that I have a fantastic answer. It's a little bit nuanced. It's a little bit opportunistic, and I, other than that, I would wonder if anyone else has any ideas or whatever. But sorry.
Yeah,
Or
that's been our, yeah, I think it is really tough to align, and I don't fault, you know, I know they have an array of challenges, but I'm wondering if maybe a better investment of time and energy are really to work through the community reinvestment funds. You know, that's maybe where the flexibility lies within a healthcare system to do good, yeah, to make impact on community rather than think about value-based payment models.
yeah, I honestly, I think that is a good idea. And like to keep all of our options and doors open, and those community funds are really important. So for something, so Sarah, Dr. Taves works a lot with aging populations, and so area agencies on aging would be a really important partner. And I know, you know, you already know this piece, but just sort of like in general, knowing those relevant community partners for your health interest or health area or health population is going to be incredibly important, because it's like there may not be a natural fit in with each of those strategies that I had on that last slide. But there may be, or it may be makes sense to work with the area agency on aging, or, you know, something else.
Thank you.
Adrian, thanks so much for the question. The question about additional sources, websites, books, and everything to continue learning about grant funding in public health, and funding formulas. A couple of suggestions. One, broadly speaking, would be there's what's called regional public health training centers. So in Idaho, we are located in the Northwest region. There is the Northwest Center for Public Health Practice. There are also other regions of the country that would be less specifically focused on the Northwest, obviously, but you know, the Great Lakes or Northeast or something like that. All these regional training centers have online these free compendium of resources, some of which are specifically focused on grant funding, on business planning, on budgets and financing and all that fun stuff. So I would start with the Northwest Center for Public Health Practice and branch out from there in terms of other regional training centers, and just look into their training resources and in the finance, and you might have to go into management sections, but those are really practitioner focused, usually easy, sometimes fun. So we are at time, everyone. I want to respect everyone's calendar, and I'm willing to stay and chat if others still have a question or two, but for the most part, thank you so much for your attendance. Thanks for your interest in this, and I guess thanks for paying taxes for the public health system.